Maybe that's.
Welcome, everyone. To those of you who are in London at the MindTech conference for Digital Mental Health Week, and for the rest of those across the world who are joining us, I'm Michael Ostacher at Stanford University. I'm the digital content editor for evidence-based mental health. Welcome to our Google Hangout today. We'll be discussing a new and important paper that we published in a special edition of our journal called Adjunctive Avatar Therapy for Mentalization-Based Treatment of Borderline Personality Disorders, Mixed Methods Feasibility Studies. So we'll be joined by the lead author on that paper, Caroline Falconer, who's a postdoctoral fellow at the University of Nottingham and University College London. She's been specializing in technological interventions for healthcare, incorporating design, implementation, and evaluation. Also by Keir Harding, who's the clinical lead of Beam Consultancy, which is a company comprised of clinicians and service users aiming to improve the experience of those labeled with personality disorder. He's an occupational therapist by training who's been a dialectical and behavioral therapy therapist for many years. Also joined by Kim Bullock, who is a colleague of mine at Stanford University, where she's clinical associate professor and the director of the virtual reality immersive technology clinic and laboratory here. We're also joined by Dr. Lisa Marzano, who's the associate professor of psychology, the faculty of science and technology at Middlesex University, and the digital mental health section editor for evidence-based mental health, and also by our editor-in-chief, Andrea Cipriani, who's associate professor of psychiatry at Oxford University in Oxford. At the end of this, we may be joined by Dr. Chris, who many of you in the UK know as one of the presenters for Operation Ouch, Chris Van Tulleken. He may join us later in the call, but at this point he's joined us. Lisa, perhaps you can introduce us to Digital Mental Health Week and what's going on at MindTech, and what the plans are for our special edition of our issue.
Yeah, hi, thank you. And I can just say what a great panel we have and what a great topic to be and paper to be discussing tonight. And just to set the scene a little bit, this was a paper from a special issue of EBMH, Evidence-Based Mental Health, which we decided to focus all on digital mental health. I think a link to it will probably be tweeted from our EBMH channel. Twitter in a second. Have a look. I think it is a great issue, and also it's a great collaboration, and I think the Hangout tonight is a great example of that, because it's been a collaboration between EBMH, and as I said, I'm a digital mental health section editor for EBMH, but also we had Jim Marley and Chris Hollis guest editing a special issue. But we worked very closely with the Mental Health, which a lot of you will know feels a bit restrictive to call it as a blogging site. It's much more than that, but it reviews, it talks, it discusses, it stimulates debates about evidence-based mental health, and also MindTech, which is a group known nationally and internationally for being at the forefront of lots of very exciting work in developing, implementing, and evaluating digital mental health. And this Hangout falls in the middle, quite literally, of Digital Mental Health Week, which is being sort of organised particularly by Mental Health. So there's lots of blogs, discussions. I mean, have a look. I think the hashtag is, again, that's going to be tweeted. I think it's DigiMH Week. And not coincidentally in this week, because tomorrow is the MindTech conference, which I believe, so I'm doing lots of plugs to various hashtags, I don't know if they're going to be tweeted, which is MindTech 2017. A great program. Again, there'll be lots of discussions, and I think the paper today very much falls within that. One of the things perhaps that's important to say is that, of course, you know, we all share an enthusiasm for the application of technological innovations in mental health, both mental health research and mental health practice. And I think sometimes it can be easy to get a bit excited about the innovation, the technology, the potential, sometimes even the gadgets. And perhaps this might apply particularly when we're talking about virtual reality and avatars. And just to note, to sort of not forget, obviously, that we're talking about a very difficult context in which these technological innovations are being applied, and that we're conscious that some of the people who might be viewing this either live or afterwards might find some of what's discussed difficult. So we're also going to put some links in case anybody sort of feels the need to reach for any support. Final note that I would make is about some of the language that we might be using in this Hangout and in some of the discussions that we'll be having. I think sort of, because again, we're conscious that this might be seen for quite a wide audience, and there might be some things that's worth saying beforehand about the language used. So I think Keir wanted to say a few words about that. Is that okay?
Yeah, please, Keir.
I suppose it's just really important to think that while the paper talks about people with borderline personality disorder, I think we all recognise that we're actually talking about survivors of often very serious neglect and abuse and childhood adversity. And we can recognise the kind of labelling them as disordered can come across. So I think what we really want people to know is that we're not as interested in labels as we are thinking of people who have difficulty mentalizing, people who cope in ways that can harm them, and people who have little difficulties with trust and relationships. And that's what we're thinking about rather than personality disorder.
Yeah. I think it's important to acknowledge that, and I would like to remind people that they can comment or ask questions of the panel during this discussion live by tweeting to us using the hashtag EBMHchat. That's EBMHCHAT. I also want to acknowledge, as pointed out to me earlier by Andrea Tompkins from the Mental Health, that we had a death today of somebody who's quite active on Twitter, JL, at JLPatient77. Her family informed us that she indeed had died earlier today. So we wanted to acknowledge that. We'll be tweeting out some resources for people who are in distress that they can access either online or by telephone. And so I wanted to make sure that we acknowledge that as we were starting. Carolyn, why don't we have you begin? You can unmute and tell us a little bit about your paper, and I think that will open up into a broad discussion about both the treatment of patients like the ones that you studied, but also about the use of technologies for the treatment of mental disorders.
Absolutely. So I'm just going to share my screen with everybody now. So I've got some slides, and I'll take about 10-15 minutes to briefly discuss the paper and show you some material and get to the really interesting results that we got. So if you bear with me a second. For those who don't know anything about borderline personality disorder, I thought I would just briefly introduce that. So there's a worldwide prevalence of borderline personality disorders, about 6%, so 6% of the global population. And it's really characterized by instability. So that's an instability in emotion, it's an instability in self-identity, and instability in relationships, and there's a lot of impulsive behavior there as well. And it's incredibly distressing, and this is often accompanied by thoughts of suicide and self-harm. Now, one of the things that underlies borderline personality disorder is poor mentalizing skills. So our mentalizing skills is our ability to notice and understand the thoughts, the emotions, and the behaviors of ourselves and others, indeed the motivations and intentions of ourselves and others. So when this skill collapses, the world can be an incredibly frightening place and an unpredictable place that really results in that instability that I've talked about. One of the therapies for trying to improve mentalizing skills for borderline personality disorder is a mentalization-based treatment. It's a very long-term therapy, so certainly in In the study, the participants were in a therapy, an 18-month-long therapy, where they came in 3 days a week. I mean, that's a huge commitment in terms of the patients, but also the services providing that therapy. So there's I'd say decent evidence base for mentalization-based treatment in terms of its impact on reducing hospitalization, inpatient stays, depressive symptoms, and also improving that interpersonal functioning, improving relationships. So if I can give you an example of what a mentalization-based treatment session would look like, you can have it on a one-to-one basis, or you can have it in a group context. And certainly in our study, we focused on the group context. So a patient would come along to the group, they would have an incident or an event that they've struggled with that maybe aroused in them a lot of affect, a lot of emotion, or some conflict and ambiguity, and they would bring it to the group. And the therapist would help that individual talk through the event, really talk through the process of the event, building up quite a detailed picture of what happened, who was involved, the kind of thoughts, the behaviours and the emotions that occurred throughout that process. And then it's really about micro-slicing that process to understand where mentalization collapsed, where that person was unable to think about an alternative interpretation of the event. And when that's established, it's almost then opened up to the group, and the group are invited to offer alternative perspectives. And through that alternative perspective, you can have a sort of a reappraisal of the event, reappraisal of the meaning of that event for the person, and also hopefully a reduction in affect, a reduction in an emotional response to that event. So it sounds relatively straightforward, but it's actually an incredibly complex and quite taxing process for everyone involved. It's quite mentally taxing for the therapist and for the individual bringing their event, but also for the group to try and keep a hold of all of these things going on, all of the thoughts, the emotions, everybody involved. So we were looking at ways to improve this, and we thought that virtual reality and avatar software might be one way to do that, because it's a visual externalization of what's being discussed. So the aims of the study was really to look at the feasibility and acceptability of adjuncting the mentalization-based treatment with an avatar software. And we kind of have some tentative hypotheses as to whether this would improve the delivery of the therapy, so just make it easier for people to follow. But then this type of software that I will introduce in a second has a specific feature of perspective-taking. Now, perspective-taking can facilitate the mentalization process. So we had this hypothesis that maybe that function would facilitate mentalization in the group. What I want to do now is show you a very short 2-minute clip of the software. There's no sound, but there's text on the video, and it just gives you an idea of what the software actually looks like. So this video is not a created animation of the software. It is actually what you would see if you were using the software on your desktop. Okay, so I'll just play that for you. So it's about 2 minutes long.
And feel free to narrate if you see them.
Yeah, free to narrate it, yeah. So I don't think you can all hear it, but I can hear some quite cheesy piano music. Oh, it's quite nice piano music, actually. So this is the software. It's called ProReal. And the idea is that it's a sort of medieval countryside landscape, and you can populate it with avatars. And those avatars can have different colors, different sizes, different postures or behaviors that you can assign to them. You can also assign like internal monologues to those avatars, so they usually end up as floating heads around the avatars. There's lots of props that you can add, so you can see there that there's a fire. There's a lot of symbolism and metaphor to be used. And again, you can use this camera perspective taking function. So there's a free camera, so you can float around and look at what you've populated the environment with. You can look just over the shoulder of any avatar that you've selected, or you can go into like a first-person perspective, so you can look through the eyes of that avatar. So just shifting perspective here. And you can save the scenes that you've created. You can come back and revisit them. And there's a different media that you can use it on. So we actually used it in our study on a very large touchscreen. But you can use it on a tablet or a PC or a laptop. So let me just take you very briefly through the study design. So we implemented the study in the Touchstone service, which is down in South London and Maudsley NHS Foundation Trust. It's at the Old Bethlehem Hospital. They offer an 18-month mentalization-based treatment program where patients come in for 2 to 3 days a week, so that's a full day, and they receive a variety of different therapies, and group mentalization sessions were one of them. So what we decided to do, because it was such a long-term therapy and we were just looking at feasibility and acceptability, we offered 4 avatar-MBT sessions, and this was predominantly within the group setting. And we measured some self-report measures of mood and some self-report measures of mentalization, but really mainly we were focusing on the qualitative interview, so trying to get feedback from participants, so their attitudes and their beliefs about the software and whether it was helpful or unhelpful, that type of thing. So looking at the self-report measures, we didn't find any change in mood or mentalization across the 4 sessions. But to be honest, we weren't really expecting this. This is 4 weeks out of an 18-month-long therapy. But the important thing is we didn't see any deterioration here. So we're quite happy with that. But the really interesting stuff comes, I think, from the qualitative. And I cannot stress enough how enthusiastic participants were, and I was really blown away by their comments and the richness of this data. So we went through a process of thematic qualitative analysis, and we came out with 6 different themes. 5 of those themes are related to the usefulness of the software, and 1 is related to how best to implement the software within the therapy program. So the first one is really about the visual nature of the software helps the participants to express themselves and ergo understand themselves. So the ability to use avatars to change the postures, to attribute color and size, allowed people to resonate with the images, but it also allowed them to connect with different thoughts and feelings and emotions that they were having and that other people were having in the scene. Which I think is a really nice example of this visual externalization of the narrative that they would just normally vocalize. The next one is that the visual narrative helps participants keep track and actually participate in the group. So this is touching upon this hunch that maybe it would help the process, the delivery of the therapy. And, you know, people acknowledged that they had trouble concentrating on the content in the session. There's a lot to focus on, but with the software, they found it really helpful. They were able to keep track because it was physically in front of them. All of the information was there, and it was almost like a shared language between the participants in the group. And people said that they could provide more feedback, that there was more discussion in the group as a result of using this software, because you can see it and because you can remember it really, really quickly because it's physically there. The third thing that came out was a little bit difficult to quantify, but there was constant remarks about the use of the software giving a clearer sense of the bigger picture or the situation as a whole. So providing this holistic view of what was going on, as opposed to perhaps being stuck in one kind of egocentric view of the situation. And it's perhaps giving a little bit of distance there as well. The fourth one, which again is touching upon these tentative hypotheses that we had around perspective taking. So people reported that the perspective taking functions allowed people to mentalize a bit better, that it was just easier to notice the emotions and the thoughts and the behaviors of others using this these perspective taking functions, because it was literally there in front of you. Even though some people acknowledged, certainly there was one person that acknowledged that you'll never really truly know what that person is thinking in that moment, but the opportunity just to have a shift in perspective on a scene that you created in a virtual environment was enough for them to begin that process of looking at alternative perspectives, alternative understandings of the event. And the fifth one, which I think is actually really quite interesting, and it's slightly paradoxical given that the reports from participants was that the software was really quite powerful, but they also said it gave them distance to think clearly. So this one male participant very beautifully articulated this, and he said, to take all of the thoughts and the feelings out of my head and out of my body and put it out there in front of me as a separate thing is kind of revolutionary. He said that when you put them, so these thoughts and emotions separate from you out there, you kind of look at it from a different aspect and you're not governed by those. So there's something about the software that allows them to externalize but still engage with the material. And what we know about mentalizing is that as soon as your arousal increases, it shuts down your ability to mentalize. So when your emotion is high, you can't mentalize very well. And the software is allowing them to engage in very emotive content, but in a way that sort of contains their emotions. So I think this is particularly nice. And then the sixth and final one is about where the software was best placed. So the majority of people experienced it in a group therapy setting, and they said that this was best because it allowed other people to contribute and give their own perspectives. They thought that it might be a bit tricky by yourself, that you might be missing out on all those alternative perspectives. So the group is really modeling this. But people said that they did see the value of doing one-to-one sessions using the software with a therapist, particularly if you have something very personal that you don't want to bring to the group, or something that just needs a little bit extra time and a little bit extra focus. So off of those results, what we can conclude is that the software is a promising approach to mentalization-based therapy. It's at least feasible, and it's acceptable to clients, both in terms of we didn't see a deterioration, but their comments were really encouraging. And I think the richness of the data hints at potential mechanisms of change. So what this software is actually doing to bring about change, which I was really excited about. And in terms of future directions, which we might discuss in a moment, really we need to look at clinical effectiveness. So we need to have a larger trial of this. We need to really establish the mechanisms of change in a systematic way. And we need to establish the potential for service efficiency. So what does this software offer? Can it accelerate or shorten the mentalization-based treatment? Can it improve adherence? And I guess off the back of that, there's a case for health economics as well. So that's just a very brief description of the paper. So I will stop sharing my screen now and open it up to the group.
That was really terrific. People can unmute their microphones so that they'll be able to participate in a discussion. Caroline, so tell me, so it's group-based. So in the process of doing this, so what is it actually like? Just before people get started, what is it, the actual experience like for the patients with the therapist? The therapist is involved during this VR session. So,
Yeah. So what is it like on the ground? So I have to say that while I was the lead researcher on this, that we had a lead therapist. Her name is Penny Cutting, and she's also the manager of the Touchstone site. So she delivered all the therapy and managed that group. So the setup in the session was up to 6 people. And they centered around quite a large touchscreen monitor, and they had a keyboard that they could use, or they could just type in using the touchscreen. And Penny would really invite people to come up and really get hands-on. So they were driving the software, and Penny was facilitating from the side, and then it would open it up to the group. In terms of what it was like for people, the group sessions are challenging anyway. There's a lot of social anxiety bringing content into this group, a lot of uncertainty in terms of the relationship with the other people on the program. So it can be incredibly challenging, and it's an incredibly brave thing to do, to bring content into a session and share it with people. But some people said that having the software there allowed them to have a focal point. So the focal point wasn't necessarily on them, it was the content that they were bringing and presenting on the screen, which I think I think it probably helped those who were particularly anxious.
Well, that makes sense. So it's really a group therapy that's facilitated by this VR technology.
Yeah, exactly. So we were sort of swaying between where best to place it. So we thought, well, on a one-to-one basis, it'd be really intimate and you can get into a lot of detail. But then we had the opportunity for group-based mentalization sessions as well. And Penny Cutting in particular thought that this was where a lot of the magic happens. There's a lot of modeling within the group, and it's mentalizing in practice with other people. And so we focused on that. However, group attendance isn't always great. So there were some individuals who did experience a one-to-one session, but purely because people didn't turn up for the group.
And you didn't let that go to waste.
No, absolutely not. No. Absolutely not. Because this was, I mean, the way that we implemented it was that this avatar-MBT group was offered in addition to everything else that they got on the therapy course. Yeah. So it was time that we didn't want to waste, and Penny put a lot of energy and time aside to offer this to the people on the therapy course. Yeah.
Kira, do you have a comment? I also want to encourage anyone to just jump in, not be shy. It's a group setting, and there's a little social anxiety, but please, it's fine to jump in.
I suppose I was thinking when I first read the paper, I was picturing people with VR headsets on, all in different rooms, and they kind of come together for their group. And it's what you're describing sounds very different to that.
Yeah, absolutely. Yeah, I think people do have this. So this is desktop virtual reality, and it's immersive to an extent, but it's still a tertiary experience. You know, you're watching something and resonating with it on screen. I think there is a lot of potential to go that way with headsets, particularly with the software. I think that's pretty much in the pipeline, actually. But it's because it's not as fancy as that immersive virtual reality kit, it actually allows us to implement it realistically within the NHS. It was relatively easy to implement in the NHS in terms of information governance, and you need a laptop or a touchscreen monitor, and we were kind of ready to go. Penny had training in the use of it, but then she managed to communicate that to her patients, and they managed to use it very, very well. And also I've worked with more immersive virtual reality technology, and there's anxiety around the tech and wearing things, and all this sort of space age technology can bring something. But what we used was a lot simpler.
I think when you were talking, I was thinking about the value of being able to put thoughts into pictures and then have some kind of discussion around that. And then there was a little part of me thinking, but isn't that done for years? and I was kind of thinking, you know, could this be done with a big flip chart and a pen? And I assume you're going to say not.
No, I have a variety of reasons for that. I mean, people do use flip charts within these sessions. They really do. But I don't think you get the level of kind of emotional resonance with the avatars on the screen. And you get that through color. You get it through increasing the size of it, and it's very dynamic and fluid. And you get to assign behaviors, and you're really kind of resonating with the behaviors of the avatars. And the fact that you can take perspective, you can't do that on a flip chart. You can maybe move around the room, but it just offers tools that pen and paper can't.
Yeah, I was having the same thought too. Do you think of this as like a you know, high-tech art therapy? Like, do you think it's similar to art therapy in that you're using symbols and things other than language to tell a story? That was one of my questions.
It's a good point. So it's often it's often compared to like Santry Therapy, using kids. So you have like a big sand pit and you use toys and things like that. But again, it doesn't have this kind of interactive aspect. It's not Santry isn't dynamic, and you don't get the movement, you don't get the shift in perspective, and that's what the avatar the avatar software brings.
Did you notice any difference? So it sounded like they had options to have sort of an egocentric view or an allocentric view. Were there any patterns or observations you noted with that? Or how did you vary that? And did the patient have complete autonomy of that?
So the patient had complete autonomy of that. Penny may suggest, well, perhaps you could view this from another perspective, but there are 3 different options, and I think she gave them free rein on the options, the perspective options that they could take. We didn't monitor it, but that is something that I'm particularly interested in, and it would definitely be something that we would look for in future studies, looking for those patterns of, are they really going into the first person perspective, or are they mostly in the free range camera and giving this bird's eye view, and the potential impact of those different types of perspective taking, and how that feeds into some of the comments that they've given. So is the camera eagle eye view related to this idea of having a holistic picture, but is the perspective taking really linked to a first person egocentric view? So I'd be really interested in future studies to look at that.
We have a comment. We have a comment from, oh, I'm sorry, go ahead.
No, I was just going to say, in a group context, I guess you also have the issue whether they're commenting on their own, on a scene that they've created, or somebody else's, because even from a slightly more external perspective, that might be quite interesting. I can see how in a context, not be the one kind of guiding what the avatars are doing, but reflecting on it.
We have a couple comments from Alistair Forrest at Alistair Forrest with 2 R's. On Twitter, who says this all makes me think of psychodrama. Moving at this from another way, from theory rather than from empiricism, is it worth thinking about the psychodrama literature? I think this is really sort of a question about mentalization-based therapy. I think it's probably worth
yeah. So what that it was Alistair. Was it Alistair? Alistair, what you might find interesting is that actually the creative director of the software is a drama therapist. So a lot of his inspiration has come from that, but not everybody can stand up there and act and embody a character through drama therapy. Likewise, if you're going to do like 2-chair therapy, you have this problem of imagery and mental imagery and the struggles that people can have with that. So the software is an alternative. It's a visual externalization of what's going on for them rather than acting it out. And also, if you act it out as well, you're maybe bringing in a lot more embodiment into what it is that they're bringing to the session. And I'm not sure how we'd be able to control the arousal in the moment, recreating those scenes.
Well, it also raises the question then of therapist training, right? So if you're having a software that will do this for you do you have to have specialized training in the therapist who's facilitating a group in these different forms of therapy, or can you use the software to then enable this kind of treatment to have wider dissemination without requiring the intensity of training that you might otherwise? Do you have any thoughts?
Good question. So my understanding is that mentalization-based treatment you can be trained up for that without years and years of training, and relatively inexpensively as well. In terms of the avatar software training, I think you do need to get used to it, and you need to be open to using it creatively, and some people struggle with that. Some therapists struggle with that, and being creative in the moment. And there's a lot of symbolism in that software as well, and there's some difficulty. So the time needs to be spent, and indeed in previous studies using this software, they found that the time that the therapist takes practicing the software within their specific model improved outcomes. It was associated with outcomes, so not necessarily causal, but it was the practice time had an association with outcomes. But I mean,
perhaps linked to that point, because I've read the paper, obviously, really enjoyed it, and I was conscious that one of the things you pointed out was that participants were generally very positive. There was no negative feedback as such, but one suggestion for improvement was thinking about having some urban scenes, for example, and sort of slightly more realistic things. When I saw what the program looked like, I also wondered about that, because I guess there's a lot of symbolism, and it's a very sort of, probably rural is not even the right word to describe what the setting is.
Fantastical almost, isn't it? Yeah.
But then having said that, the more I think about it, the more I wonder whether that's actually possibly a good thing. What your thoughts were, particularly in a group context, and particularly people are discussing.
Yeah, so I mean, there wasn't any really negative comments about the use of the software, or the comments about it getting in the way of the therapy process. There were suggestions, as you said, that they would like more urbanized or more kind of social settings, so maybe like in a bar or pub or something like that. Having said that, they would come back and say, "Oh, that we may do." So an example of one was someone had brought content about an event that happened in a bar, but they used the wall as the bar. So they may do, and the sense that I got was that it didn't impact their overall experience. It was just something that they thought might be helpful for them. But I mean, the software, the company that owned the software, they've kind of battled with this, and I think they are in the process of making other scenes, but people generally got on with the software, and really it's metaphorical, and it's, for some people, it's a very safe environment as well. For others, it is very alien, and maybe that is a bit of an impedance to engaging with the software. But generally, people get on with it. They see it as a metaphorical, symbolic land that they can project themselves onto.
What I thought was really interesting, who was going to go? What I thought was really interesting was that if we're thinking about difficulties with relationships, then we tend to be thinking about non-verbal communication a lot. And I was quite interested that the avatars are quite faceless and generic, other than their size. I was quite interested in the impact of that, because you lose a lot in the communication when it's totally blank.
Yeah, it's a really good point, actually. You are losing a lot of particularly facial expressions, and there's clearly a defined set of behaviours. I can't say anybody really mentioned that, and Penny would be going through that, going through the process and asking them what they did notice, what were the triggers for them in certain situations, and it might be the facial expressions. And there's an opportunity to kind of write that in and label that within the avatar, so it's there and it's noted. Yes, there's potential to grow the software and get more facial features involved there. Having said that, even in immersive virtual reality, the use of facial features is still not great. You don't get the level of subtlety that that people can be sensitive to. But I think it's a good point, and they have kind of tossed the idea about, and but again, people kind of get on with the software. It is limited, and it's almost like a comfort and a boundary to that, actually. But that's not to say that
I suppose I was thinking as well that therapy is about asking people to put their thoughts into words. And one of my initial reactions was that people to put their thoughts into pictures. And actually we're getting people to put their thoughts into pictures and then into words. And it seems like this was a real aid to doing that.
Yeah. Yeah, what are your thoughts about translating this, or the next technological jump to immersive technology? And what's fascinating to me is too some of the studies that people with, I'll say, quote, borderline, or have been identified with that term, tend to have embody avatars more quickly than others. It's just a marker of interoceptive sensitivity. And so maybe there's some way to leverage immersive technology because of that tendency to be able to take on that visual illusion more quickly. And any thoughts, or what your future plans with this?
Really interesting. I didn't realize that the embodiment process was faster for those individuals. That's really interesting. What are the plans? Not immersive at the moment, because we're looking at, our goal is to look at the efficacy of this within treatment, and then we'll be looking at if the results are good and safe, then we'd be looking at trying to get this taken up within services and being used at scale. There's some thoughts about giving people the opportunity to have it on a tablet and take it home, to like a stripped back version. Some of the participants said that they thought that would be useful. It's like an aid memoir after therapy. And we're still sort of playing about with the idea of group versus individual avatar-MBT. I can really see, for me, because I originally started in immersive VR, I can really see how it could be easily adapted into. So we're looking at perspective taking and to use immersive VR and really go one step further and embody that perspective. And I'd be interested academically and clinically, obviously, the effects of that and looking at the mechanisms underlying that. But it's time and money and resources, so we just have to wait and see. We're trying to apply for funding at the moment to do a bit of a larger scale study, but we're kind of grappling with this idea of trial design, so cluster trials versus kind of standard randomized control trials. But yeah,
I mean, speaking of time and money, so is that a barrier to the development of the software?
Well, so the software is owned by a company. They've had resources from NHS initiatives to kind of bring it in line with NHS services, so National Health Service here in the UK. I mean, they're using it in the private sector at the moment, and it is, I think that the barrier for them is evidence. So what is acceptable to NHS commissioning bodies for them to procure it and bring it into services? Is it a little bit more fancy than a flip chart, or is it a whole new intervention? And in which case, we need to build up the evidence for it. And that's the barrier at the moment. And I think it's a barrier for a lot of virtual reality interventions at the moment.
So when you say evidence, what specifically do you mean?
So it's a good question. Are we needing substantial RCTs across a variety of different trusts, different... Is it good enough to say, well, it works in groups, so then the evidence must mean that it would transfer to one-on-one therapy, or do we need additional RCTs for that? It's just quite complicated in terms of what we need for evidence. Or would they be happy knowing that it's relatively safe and patients are happy with it?
Right.
I don't think we're there yet in terms of the data that we have. We still need to do some more trials. But do we need to go the long haul into these RCTs or not? That is the question. I think the question for the field as well.
Right, because in the United States, for devices, the what is asked of devices is different than what is asked of drugs or, and so for drugs the bar is much higher for safety and efficacy. For FDA clearance for devices, I think you just have to show that it works. I'll use air quotes, it works, and that it's safe. And the bar for that is much lower. So for instance, if you show in a single group without a comparison group that there's a change over time, that's inadequate for the FDA as long as you pre-specify prior to your trial what amount of change would be considered clinically significant. And so you can just do a paired t-test on a given outcome.
Wow.
And if that occurs and then you don't have any deaths or some other safety outcome, then the FDA will clear your device for use. And so obviously that's not the case for drugs. The drug, both safety and efficacy for drugs is different. So what is it for NHS, and what is the amount of evidence? So you would, if you were going to do your avatar VR mentalization-based therapy and use it in the United States, you would just have to say that it was going to produce this outcome, and then do a study and show that in a cohort of whatever number of subjects you need for the effect size you're looking for, that you see a change from baseline.
Yep. Okay.
I assume that it's different for NHS since they're paying for things too.
Yes.
And the FDA only says the FDA only protects us, doesn't pay for anything.
Right. Okay. Yeah, that's interesting to know. That's so different from the US. I think the NHS, in psychological therapies, they work in evidence-based practice. So we need the evidence. And at the moment, the kind of gold standard for that is RCTs.
RCTs.
Yeah. Randomized control trial.
Sorry, Caroline. One question about the comparator, because not just the study design. It's
Absolutely.
So how would you compare the VR intervention with what?
Yeah, so ideally, within a same service, we could have a group of participants who are receiving the avatar-MBT versus a group who are just receiving MBT treatment as usual. But there's a lot of, the difficulty is that there's a lot of interaction with people within these therapy services, and there's the potential for contamination. So there's a potential for chat between the two groups, and that's something we're struggling with at the moment. And whether, is it enough to say that that's a natural organic process, and we just have to inflate our sample size to account for some kind of crossovers between the groups? So we're trying to think about that, but something active, and in my mind it would be those receiving MBT treatment as usual. What are your thoughts on that? Or are you?
I mean, it makes sense from a clinical point of view. It's only that when you randomize patients or people, the assumption is the so-called equipoise. So in principle, they should be happy to be randomized to one thing or the other. And my question mark about all this fancy stuff is whether you're selecting patients who are really motivated. And so when they're randomized to the standard mentalization, they might say, no, sorry, I'm interested in the new stuff. So that's a big problem, I think.
Absolutely, a huge problem, yeah. And the potential conflict that might create, or divide that may create within a service. Because you could compare, you could take that variable out and you could compare services, but then you're adding the extra variance that this is a completely separate service, different clinicians, different setup, different perhaps community of patients coming into that service. So you're adding more and more variables. So we are trying to figure it out at the moment. And it's a challenge. It's intellectually very challenging and rewarding, but a challenge.
Yeah. Well, but I think we talk about this on almost all our Hangouts, that the issue of equipoise and the effect that it has on bias and how studies turn out. So, I mean, it's quite difficult in a study where people are looking at novel technologies to actually have true equipoise when you randomize people, because it's likely that most people, as Andrea points out, would be more excited to get the new technology than to not, and therefore their outcomes and what they say, you know, since they tend to be subjective, might be biased in the direction of this. But that's a problem with almost every treatment that we do, and unless we do widespread trials in which the investigators don't have any kind of interest in the outcome, whether it's academic or financial, it's very difficult to have any of our trials, from medications, psychotherapies, services of any kind, to allow us to have actually a true equipoise with this. So since that's never going to happen, it's probably okay.
You try telling that to the funding bodies.
Yeah, exactly. Kim, maybe you can tell us a little bit about what you're doing at Stanford now, and what your group is looking forward to for at least the near term, in terms of VR and where your focus is.
Yeah, so we have a whole program now at Stanford, but I can so there's a lot of different people doing different things in the VR and immersive technology program here, but I'm really interested in this study because my research interest is people with psychosomatic illness, specifically conversion disorder, now called functional neurological disorder. We're following suit from the UK because you guys are always ahead of the curve with mental health. And so they have a high comorbidity with quote, borderline personality because of, their incidence of trauma, emotion dysregulation, alexithymia. So I do a lot of DBT interventions, and also developed a VR intervention looking at mirror therapy. So using it actually for motor reprogramming. So that's just a whole nother use of VR and a potential use. So I think there's so many different ways that you can apply it for, enhancing learning, teaching skills. The way you've applied it here is sort of another way to do art therapy, or to kind of bypass language. Yeah, so we're using it in all sorts of ways, and I'm really interested with the immersive technology, how we can reprogram the motor and sensory cortex, and possibly implicit biases and emotion dysregulation on a more kind of physiological level.
And sorry, Kim, how do you evaluate these interventions, these new approaches?
Well, yeah, we're trying to figure that out as well. So it's very exploratory. So yeah, it's hard to be rigorously scientific at this point. We're kind of creating some manuals, exploring, looking at outcomes. So I'm doing mirror therapy. So we're delivering kind of swapped limbs for people with their motor and sensory symptoms, and seeing if they get better outcomes as far as handicap compared to treatment as usual. So we're kind of using our control arm as just treatment as usual. But it's very noisy, messy, and I think we're in this whole new realm of exploratory work because there's nothing behind us, so we have to, it's kind of a creative time.
Right.
Can I open up then a question about that? Because, you know, to some extent, we know that virtual reality has been around, well, at least since the 90s, but I think sort of mid-60s. So why do you think it hasn't, this sort of therapies haven't taken off before now?
Huh.
And will they take off?
Yeah.
Well, accessibility, like I've just become, and I'll open it out to other people, but you know what, the platforms were so clunky and hard to disseminate. It was a dissemination issue. And this SciAS, in our clinics, we're using this program called SciAS that's web-based, because in an hour, you know, somebody like me that's not very technological savvy can just, you know how to deliver it. So I think it's the delivery packages are becoming much more efficient. That's my take, but I don't know. What does everybody else think?
Yeah, I think it is about accessibility.
I wonder as well if technology is just part of our lives now. You know, I remember when it wasn't an internet, and now I see people doing everything digitally. Phone call, they'll send a text, they won't even use words, they'll send an emoji. So there is something about, whether we like it or not, our lives are becoming a lot more digital.
Yeah.
Like, got some discomfort around the use of technology and the use of virtual reality. It's just going to happen. It is just going to happen. Yeah,
I think it's also that we have different conceptions of privacy, and what you had said earlier about data governance, or what, I don't know exactly what the expression was, but you know, we have really important issues about data privacy. But now that people are sharing as much as they are, whether it's on even on professional social media platforms such as LinkedIn, but certainly on Facebook, people have you know, just by searching, you're giving up privacy. You're letting people know, you're letting companies know what your interests are in terms of shopping and your news and your friends. And so this has really sort of changed how people look at technology, I think.
And I guess, that was partly...
Yeah, go ahead, Lisa.
In the background of my question, because I do sometimes wonder whether the technology wasn't ready for us, so it was us not being ready for the technology. If that makes sense.
No, I think exactly. I think what you're saying is exactly. No, I think it's exactly right. It's also that the sophistication of the software and the modeling has gotten so much greater, and the processing power has gotten so much greater that even what you showed us today, Caroline, which is what, you know, I don't remember exactly the terms you used, but you know, it's sort of not rudimentary sort of figures, are still really quite sophisticated compared to what was available even in 5 years ago. And so part of it is that it's acceptability and usability of things, and the expectation. I don't know, I have a 17-year-old who has an Xbox, and my wife comes in when he's playing and she says, "Who's playing?" Like, he's playing FIFA. "Who's playing?" And he's like, "What are you talking about, Mom? It's the computer." In other words, there's nobody playing. It's a computer game. She comes in and takes a quick look and thinks it's an actual game. So the animation has gotten really quite sophisticated. I think for me, the question for all of you before we wrap up here is sort of, I mean, this is very novel, what you're doing. You're sort of adding on a VR experience to an established therapy in a group setting within the NHS and a group of patients who are getting longitudinal care. So what is this going to be what the future holds? In other words, is there going to be much more use of technology just to facilitate the treatment that we have, and in what form do you think that will take?
I hope so. I think it's about offering tools. I'm actually quite skeptical of the role that digital can play in mental health, even though that's the area in which I work. I'm very focused on the therapeutic alliance and the connections between human beings. So for me, it's really about increasing accessibility to evidence-based care, and providing tools that are going to facilitate that one-to-one interaction or group-based work. I think it's about you know, these therapies that we have already aren't great. The evidence, you know, the impact of these therapies isn't great. There's so much room for improvement, and I think technology can come in there and make that improvement.
Yeah, that's terrific. Well, I think we're at our hour. This went much faster than I thought it would, and but I do feel like we need to close out.
It went quite slow.
Yeah, no, and there are many questions and comments on the internet. So go, when we're done with this, everybody check their feed and look at hashtag EBMH chat. Questions about this. I think it's been a lively discussion. I think what you've done, Caroline, is really remarkable. It's taken a very advanced technology and embedded it into an ongoing real-life treatment with real patients who are getting other kinds of care at the same time, but it looks like it's certainly not harming them, but maybe helping facilitate their treatment. I want to thank everybody for joining us. Caroline Falconer, Keir Harding, Kim Bullock, Lisa Marzano, and Andrea Cipriani. Remember, this will be archived on YouTube, so you can watch this video later. The paper is free open access right now on the evidence-based mental health BMJ website. We have a guest. And I hope that you join us again for future chats. Thank you very much. I also want to acknowledge again the passing of one of our Twitter friends, Jacqueline. So I hope that all of you who need help will seek it as you need it. I appreciate everybody for joining us. Thanks very much, and see you at our next Hangout.
Thank you.